To continue with children who have alterations in fluid and electrolyte status, we were talking about burns and types of dressings. This is a type of dressing. Dressings for burns for children and adults include dressings that help immobilize the area. So when your skin and your muscles and your tissue constantly are moving, it's very hard for new skin and scar tissue to heal. Your scar tissue will continue to remodel in areas of great movement. So they put on these dressings to help reduce the movement. This is called a Job's garment, and the Job's garment is on his arms. I don't know, but some of you might recognize those Job's garments from long-term care and patients who have very, very thin skin that will tear very, very easily. So those types, it's padding and it's very firm. This right here is called an airplane splint. So the Job's garment holds the skin as immobile as possible. These types of garments are to stay on for 23 hours straight. They can take the garments off, take a shower, and then put them back on, okay? Or get cleaned up and then put them back on. They must have them on for at least 23 hours a day. Now, the things like airplane splints and different splints like that, their purpose is to hold the area in the greatest amount of movement. So see how his arms are up? That is so when everything heals, it doesn't contract it and prevent movement, all right? So we want them to have as much movement as possible, all right, while they're healing, excuse me. We are going to do a burn case study together. You do have it in your packet, and we are going to do it together. Yeah. So now we are going to move on to children with alterations in their gastrointestinal system, okay? So we're going to talk about elimination first. With that, our exemplar, or what we're going to work through, is Hirschsprung's disease. As you can see there, it's a congenital aganglionic megacolon. Try to say that fast. It is called by the absence of the parasympathetic ganglion cells within the muscular wall of the distal colon and rectum. So what that means is the rectum and that adjacent colon are missing ganglion cells. Those ganglion cells are what contract and relax that muscle, all right? And you can see there that there is no peristaltic action to that part of the intestine. 1 in 5,000 infants are born with this. And of course, there's different severities, just like with everything else we're going to talk about in pediatrics. This is an illustration. This is a normal colon, and this is what it would look like to have that enlarged, or megacolon, they might refer to it as, okay? All right, so here we go. Signs and symptoms. So the first sign and symptom is going to be that absence of meconium stool in an infant. They do not pass that stool, okay? They are going to have that bilious vomiting, so bile-induced. It's kind of the sign and symptom of an obstruction. That part of the bowel is not working well. Severe abdominal distension. constipation, ribbon or pellet-like stools, poor weight gain, feeding intolerance. Now, you can see there are serious complications that go with this. So, a child who develops enterocolitis, this occurs in about 6% of infants with Hirschsprung's disease. They are at higher risk for developing enterocolitis if Hirschsprung's is not diagnosed within the first week of birth. And it's seen much more with children with Down syndrome, okay, which we're going to talk about at the very end of pediatrics. Enterocolitis makes inflammation of that digestive tract in the large and small intestine. So what we're going to see is an increase in diarrhea, which causes a loss of bicarbonate. Because of that, you're going to have the pH go lower, so the acidity is going to go higher. Because of this, they are at a greater risk for metabolic acidosis, all right? They will also at the same time excrete large amounts of sodium and potassium, so you have to consider the possibility of them becoming hyponatremic or hypokalemic, okay? Also, sepsis is another severe complication of Hirschsprung's. All right, so physical exam, we're going to see that severe abdominal distension, okay? A digital rectal exam can be performed, and what you're going to find is there's going to be a lack of tone. Because there is no ganglion cells there, there'll be a lack of tone to that area. X-rays are going to show different air patterns. The rectal biopsy, you're looking for that tissue that does not have those ganglion nerve cells in it, okay? So that's what they're looking for when they do those things. All right, so Hirschsprung's require surgery. So it is our job to prepare and support the patient and their family. The patient often ends up with a colostomy. It is sometimes temporary and sometimes permanent, all right? You can see there's a video on the pull-through procedure, which is one of the most common types. The big thing that we have to consider postoperatively is not to do any rectal temperatures, all right? It's very dangerous and it can disrupt the surgical site. Now you can see there prior to surgery in the preoperative period, we're going to educate, support the child family. They should be NPO. They may have an NG tube to help empty out their stomach, so it would be to suction, and they would be getting fluids to help keep them hydrated. That's what we should be expecting. As far as nursing care, you can see here pain management will be important. NG tube to suction. You may get some old blood in there, so it might be dark brown, like coffee ground. You should not see any bright red blood. That's indicative of bleeding. We're going to assess the abdomen for distension. You can see there we would have to teach colostomy care if they have a colostomy. So you have a handout in your packet with rectal dilation on it, rectal dilators. And that paper explains how we're going to use those. So what's basically going to happen is the parent's going to go home with these instructions and a set of these rectal dilators. And they are going to follow those instructions and progress with those rectal dilators. And what that does is it's going to prevent those strictures. Remember we talked about strictures with burns. Strictures can become very painful and they can create a loss of function to that area. So that's very important to help prevent that. They may also be on a bowel program. As far as community care, they will require home health. You can read that slide there. Parents should seek support in support groups. This puts a lot of stress on families. Infants with colostomies end up having families with frustrations of quality of life. If you can imagine, not only do infants start grabbing things, as they develop, but they're also very mobile and growing at a fast rate. So if you can imagine trying to keep a colostomy bag and things on there, that can be very difficult for a family. Also, understand that even after surgery, children with Hirschsprung's disease have delayed toilet training, staining, and fecal incontinence. So what that means is even if they have been treated as infants, as they get older and as they're developing, they do have periods of incontinence and things like that related to that. So imagine having to go to your elementary school for the teacher, the parent having to explain to the teachers that the child may become incontinent based on this previous disease that has been treated. Imagine what that does to a child. Okay, that can be very difficult for a child to go through. All right. We're also going to talk about short bowel syndrome. You can see there, this is a condition where there is malabsorption. It can be from congenital anomalies. You can see there, necrotizing enterocolitis, Crohn's, things like that. But there is a malabsorption issue with a fluid and electrolyte loss. Okay, that's a big deal. Here is a picture of some of the conditions that may require treatment, and these are all different types of short bowel syndrome. Okay, so these are some of those children that would have to have that portion of the bowel removed, and then you can very much end up with absorption problems. As far as signs and symptoms, you can see there profuse watery diarrhea, malabsorption, and failure to thrive organic. Now, we went into detail about failure to thrive non-organic when we discussed abuse and neglect, okay? Now we are going to talk about failure to thrive, but organic. So organic, if you remember from what I briefly described previously, is related to a physiological condition, okay? In this case, we're talking about short bowel syndrome, but it can be from any type of organic physiological condition. Dehydration, electrolyte imbalances, mineral deficiency, skin breakdowns, these all can occur from short bowel syndrome. Oral aversions, so those occur when a child is not stimulated orally. All right, part of the growth and development is that oral stimulation. So oral aversions will occur without that stimulation. All right, so talking about failure to thrive but organic causes, you can see here the plethora of causes: GI, cardiac, pulmonary, renal, metabolic, of course genetic, neuromuscular, endocrine, infection, other types in there as well. Signs and symptoms of organic failure to thrive, you can see there: listless, low weight, small size for age, delayed development. So as you can see, they're very similar symptoms and signs as non-organic. So how are we going to tell the difference? Well, we're going to do a very careful assessment, and we are going to take a very careful history, and we're going to listen, and we're going to try to ascertain what might be going on. So what often happens is something is physiologically wrong with the child. If the parent is unaware, they don't necessarily know what to verbalize and to explain that's abnormal for their child, okay? It can be very difficult. You can see there the growth parameters, they won't be meeting, but we need to follow that. Careful dietary history, elimination history, vomiting, so any type of feeding difficulties potentially. Diagnosis, so we're going to look for all these physiological issues that could be. So we're going to do a lot of screening studies. We're going to do a lead screening because lead not only causes cancer, but it also causes permanent developmental delays. That is why it is so vital that we screen for lead. Checking iron, the H&H, we're checking the CBC, we're checking the CMP, LFT, so those liver function tests, PTT, albumin, bilirubin. We want to look at the amount of albumin, which is a protein, right, in the blood. It helps carry those hormones and vitamins, enzymes, right? The prealbumin shows us the body's ability to utilize those proteins in the body, right? So we have to look at all those things. As far as types of interventions, we're talking about interdisciplinary collaboration. So that means different sections and people in the hospital getting together and discussing this. So physicians, nurses, dietitians, occupational therapy, physical therapy, speech therapy, all working together. We talked about non-organic failure to thrive. So if we're talking about that, social worker, although certainly organic failure to thrive would also include social worker, psychologists, psychiatrists, child life specialists, child protective services, that type of thing. Just to make sure we discuss child life specialists. They are people in the hospital who are certified and have gone to college to help the parents adjust to medical things in the hospital. So they work at the hospital, they're the go-between. They also help with education, they help with explaining things on developmental levels of the children. They are wonderful. Hershey has several. So the bigger hospitals do, like smaller hospitals such as Ephrata Wellspan, they don't have any. But just so you know, if you're in a big hospital or a child hospital model, which Hershey is, you're going to have child life specialists, which are wonderful to work with. As far as in the community, you're going to need close monitoring, follow-ups, referrals, help with paying for things, support groups, that kind of thing. For non-organic, and we did talk about this briefly, parenting classes, we talked about child protective services, in-home follow-ups and surveillances, and placements if it's warranted. Complications of short bowel syndrome, you can see here cholestasis. Remember, that's where that bile cannot flow down from the liver to the duodenum. Cholelithiasis, that inflammation of the gallbladder from the stone formation. Psoriasis, liver failure, bacteria overgrowth syndrome. They get bacteria overgrowth syndrome from poor movement in their intestines. That causes abnormal amounts of their normal bacteria to grow excessively, okay? They're going to have poor absorption, watery stools. They are going to have a bicarbonate loss in their stools, so we do still need to monitor for metabolic acidosis. They are also at a greater risk for enterocolitis, which we discussed already. diagnostic tests for short bowel syndrome, upper or lower endoscopies, CAT scans. What we need to do to help support somebody with short bowel syndrome. Well, they might need parenteral nutrition or enteral nutrition, right? We want to monitor their fluid and electrolytes. We want to monitor their input and output. We want to try to replace their losses. Remember, we want to still do the enteral nutrition because we still want to stimulate the adaptation of the small intestine. So we want to use the intestine to help them to increase the absorption and the digestion, okay? And the enteral nutrition is that GI tract delivery. It will be based on the individual child and case, whether it's continuous or bolus feeding. So some children might just need certain feedings throughout the day. Some children might, depending on their absorption, need continuous slow feedings over long periods of time. As far as the parenteral nutrition, we're talking about TPN, PPN, that kind of thing. Frequent labs, liver and renal functioning, and you can see there the electrolytes that we're going to have to monitor. They may do bowel tapering, lengthening, and transplant. Bowel transplant for children and infants does not have a good prognosis because of the high rate of rejection. Medications that we can use to help, well, we can use those histamine blockers, you know, the famotidine or the Pepcid, those types of things, Tagamet, Zantac. The proton pump inhibitors, we can use omeprazole and things like that. Those are to help reduce the acid in the stomach. The flagell right there under antibiotics, we're going to use that to prevent the bacterial overgrowth, all right? We might see anti-diarrhea medication like Imodium, fats, so medium chain triglyceride oils, that's what MCT stands for. That's replaces the fat that they are unable to absorb and helps them increase and maintain their weight, okay? Here is a picture of PICC lines and central lines for infants. We're going to talk about those more when we talk about malignancy. We have already discussed this in our clinical orientation, but you can see here this is a kangaroo pump. This is a Mickey, remember? The G-tube, the low profile G-tube. This is an NG tube. Here's a child with a Mickey. This is the extension, and here's what it looks like for the Mickey. This is the feeding bag, and here is a Cabbage Patch doll with the Mickey as well for the infant. As far as community care for a child with short bowel syndrome, they need to go home with proper feeding techniques, education for the family on how to adequately feed their child, whether it be NG tube, enteral feeding, all right. Care of the devices. They might need to replace the feeding tube. So if they have an NG tube, parents need to know how to place an NG tube. If they have a low profile G tube, they have to know how to do a G tube change. Those Mickeys get changed every 3 months, so they need to know how to do that. Occupational therapists will be involved. Feedings will be constantly monitored for adequate absorption. Social services will be involved because this is going to require a lot of care and equipment and supplies and things like that. So this concludes our portion for the child with conditions which may alter fluid and electrolyte imbalances, and with altered gastrointestinal status. Thank you.